Okay, hello, can I be heard? All right. So do I start from the beginning?
Just one more slide back.
Yes. Yeah, this way you started from, right? Good.
Yeah. Okay, sorry about that. So I hope I can be heard loud and clear. So HIV was stigmatized in my country in the early years when it started, and it was looked at as a death warrant, and we had all those pictures in the billboards just to remind people to abstain from sex, or for those ones who are married to be faithful to their partners. So with time, yeah, we still had the ABC, the avoiding sex, or being faithful to your partner, or using condom. And you can see we had billboards that were saying, say no to sex. You have, like being a virgin is being powerful. So when you're a virgin, you're actually avoiding sex. But also with time, my country embraced use of condoms. So we had more billboards empowering people to use condoms. However, we still had stigma on that, whereby you can see people are being discouraged from using condoms. It's either you avoid, abstain from sex, or you be careful to your partner, because it showed that some of the people who used condom still died of HIV. So you can see that one saying that is 1 out of the 12 condoms failed. So that is a faithful condom user who died looking like a skeleton. Yeah, so my the early years of HIV myths and misconceptions about HIV in Kenya, it was believed to be witchcraft that befell a particular family. Like you'll find HIV clearing a whole homestead, and they'll say that the whole of that homestead was actually, bewitched. So they were dying not because of HIV or any other illness, just because somebody that did something to them. And then We had some communities that believed that the dead needed sexual cleansing by a family member. So there was one person who was actually just designated to be doing that. In case a family member dies, he's supposed to go and have sex with that family member, that dead body, so that cleanses the family or the whole homestead from people dying from the same disease. And then we had the widows of, if a son of the family dies, the widow was inherited by the brothers to the deceased, so that she can actually, the family to the brother can actually be sustained through this man becoming polygamous. Then we had young children who were raped because somehow it was believed that having sex with a virgin, you are cleansed of HIV. So the men who were diagnosed with HIV were actually raping young girls because they believed that a young girl is a virgin. So there was a lot of rape cases among the young children, 5 years and even below, so that these men can actually be cleansed of HIV. And it was, in some communities, it was very, very important that for an investment to be started, the couple should have unprotected sex. So in case the couple were in a discordant relationship, a HIV discordant relationship, at that time we didn't have even PrEP or PEP. Condom were not now allowed to be used, because if they used condom, then the investment will not prosper. So what they did is they had to start the whole event by having unprotected sex, and that was challenging when you're trying to take care of the discordant couples. So unfortunately, currently we still have stigma. This is a guy called Babu Walaliondo, that is from Tanzania. This guy made people believe that he's able to cure HIV through some herbal medicine. And we had a lot of people traveling to Tanzania, including people from Kenya, Uganda, and neighboring countries. And they camped there for a whole month. And unfortunately, the son to this man died of malaria. So we're wondering if he could not cure the son of malaria and was curing people of HIV. Unfortunately, most people stopped taking their medicine. They came back, they believed, and they died. So we lost a lot of people to this. So we still have a lot of stigma. We still have witch doctors who have not even stepped in a classroom, but they call themselves doctor. Like this one is called Dr. Gulumo. So they tell you that you call that number and they have a way of actually curing somebody from HIV. And this is something that is still happening even at the moment. So what made me get interested in HIV and key population? So initially when I was a student in the early years of 2000 in my country, there was a lot of issues that were happening around HIV that were very, very bleak. So when we were healthcare providers and student nurses, the moment you get pricked, a needle injury prick from a HIV positive individual, there was no post-exposure prophylaxis. What you used to do is used to be told to squeeze blood out of that, like prick, because they believe that once you do that, you are squeezing the HIV virus out of, out of your system. So it was very challenging. We didn't have the post-exposure prevention, so you had to squeeze and wash with jik, wash with calamine lotion and all that you could get around, any antiseptic that you could actually get around. We didn't know how HIV was spreading even from the dead body. So whenever we lost a patient, we used to wrap them in black polythene bags before they actually buried to stop the spread of HIV. And then with HIV, there was a re-emerging of TB, which had actually been controlled. But now, when HIV came, there was a lot of TB cases, and these TB patients were put in, isolation wards that had window walls, and the doctors could not enter the wards to see the patient. They could only see the patients through the windows and prescribe another medicine in case that client doesn't die by that time the medicine is supposed to be given. And also we didn't have gloves to use, to handle the HIV and all that. We had to recycle gloves by washing them and taking them to the autoclave. So let's look at the HIV picture in Kenya. So it is a generalized pandemic in Kenya. However, it is concentrated among the key populations. So the key populations are the co-transmitters, and then we have the bridging population, whereby the class, the sex workers, who actually now take it the general population, and vice versa. So when you talk about the key population, this is what we mean: people who use drugs, more likely the people who inject drugs, the sex workers, the transgender population, men who have sex with men. So when we talk about the people who inject drugs, we are interested in this community because sometimes they share the needles, and sometimes when they don't even have the drug itself, they actually borrow the blood from the person who is high so that they can inject themselves with the blood of this other person without caring if their blood group is compatible. So that is one issue that we really care about. Sex workers, we have both male and female sex workers. And when it comes to men who have sex with men, we have those men who are MSMs, but also they sell sex because they need money to survive. So it's a very important group that I was really interested in because of the HIV prevalence in it. So globally, it is also the same picture whereby you can see the sex workers' HIV prevalence is 4 times more than the general population. The people who inject drugs, their prevalence of HIV is 7 times more. If you look at the gay men and other men who have sex with men, their HIV prevalence is 11 times more than the general population. And the transgender people, their HIV prevalence is 14 times. This is according to the UNAIDS 2023 report. So if you look at my country, there's no big difference. This is the data for 2014 because we don't have the latest data for key population in 2023. So in 2014, the sex workers' HIV prevalence in Kenya was 29.3%. And for the men having sex with men was 18.2%. And people who inject drugs, 18.3%. And yet for the general population is at 4.9%. So if you compare with that, you can see that the key population is where actually the HIV tap is that we need to work on to ensure that we reduce the incidences and the prevalence of HIV in the country. So sex work is criminalized in the country. So how do we go about this programming of HIV among the key population in Kenya? If you look at the country, it is religious, whereby 60% of Kenyans are Christians, that 5% are Muslims. And by virtue of being a religious country, sex work is something that is really condemned. So, but apparently, apart from it being stigmatized, criminalized, and like illegal and all that, we still have laws that govern how we work around that. The Healthcare Bill of 2012 shows that every Kenyan has a right to attain the highest level of healthcare. So the sex workers outreach program, which I'm going to talk about, because they're the ones who are doing a lot of key population work in the country, they have worked with the government to ensure that the sex workers and the MSMs are able to access healthcare without anybody coming in and criminalizing what they're doing. So this is just some captions from the law of Kenya that says the Nairobi County bylaws says that general nuisance, loitering, importuning or attempting to procure a female male for prostitution purposes is an offense. The penal code for the country, sections 153 and 154 says that every man or woman who knowingly lives wholly or in part on the earning of prostitution or in public place persistently solicits or importunes for immoral purposes is guilty of a felony. Okay, so we have drop-in centers, we have healthcare facilities that are serving sex workers in Nairobi, not just only Nairobi, but in other cities in Kenya. But I'm going to talk particularly about this one because it is the first one that started taking care of sex workers in Kenya. And it started in 1979 as a Majengo Observations Cohort Study, whereby University of Manitoba came into Kenya. They were interested to study schadenfreude among sex workers. So by chance, they actually found out that out of the 60% of the samples that they were collecting, 60% of the samples were actually testing HIV positive by then. So they decided that they're going to actually change from looking at Shankoid and now start looking at this new disease of HIV. So what happened is the University of Manitoba worked with the Ministry of Health to see how they can actually reach the sex workers. So the first thing they did, this took time because the first thing they did was mapping to find out where can we find the sex workers, where do they operate. So the first mapping was done in 2007, and then they keep on updating the mapping process, and this one was actually done in 2019, which is the latest. So when it comes to mapping, they're actually checking out the hotspots. Where do the sex workers operate? That's what we call the hotspots. And some of these hotspots are the brothels. We have the homes and all that. So this is just a map of Nairobi County alone and the sub-counties in Nairobi. So they mapped and they found 2,539 hotspots where these sex workers are actually operating from, including some of the MSM. So in 2019, through the mapping process, we found out that we have close to 50,000 female sex workers operating in Nairobi alone. So this is an exercise that was also supported by the Ministry of Health, and you can see that is how the government is coming in supporting offering of healthcare services to sex workers, despite the trade being illegalized. So some of the services that we are offering to sex workers, they are free services, but they are being funded by CDC PEPFAR. So in the sex workers outreach facilities, we are offering information on safer sex practices. We are offering condom information, demonstration of use and provision of the condoms. We are providing the condoms free, the male and female condoms for the sex workers population. We're also offering HIV testing and counseling, STI screening and treatment, risk reduction counseling services, ARVs and HIV basic care, family planning information and services, TB screening, treatment and referral, post-exposure prophylaxis and pre-exposure prophylaxis, mental health and sexual gender-based violence, psychosocial support and referral. So the services have been categorized into three, that is behavioral services, biomedical and structural services. And all these are being offered for free to the community. So just to show that the government is in support of, like taking care of the healthcare of the sex workers, there's even a strategic plan that has been launched by the country, which is up to 2027. It says that targeting of female sex workers by HIV programming supported by government. So there's a component in the strategic plan that is actually taking care of the sex workers. So as much as the Ministry of Health is in support of offering services to this community, the population, the people of Kenya are not, supporting this. So there's still a lot of stigma. There's still a lot of, culture issues around this. So what the Sex Workers Outreach Program has done, it has established 10 drop-in centers for the sex workers. It doesn't label the facility as a sex worker clinic because it can even be burned down when the people around it find out. But we have the SWAP word, that is well known to the sex workers. When they see the sign SWAP clinic, they know that is one of the facilities that is serving them. So it is, it is embedded into a facility that is running businesses. So when somebody walks in and walks out, you never know which floor are they going to. Are they going to the SWAP clinic, or are they going to do some other businesses, like in other floors? So the facility is friendly to the key population. We call them safe space. You can see that it has colors for the LGBTQI facility. But we recently changed these colors because of some commotions that were going on 2 weeks ago, targeting the LGBTQI team. So for now, we've gone low on that because they have actually identified the colors that they might walk into the facility and burn the facility. But we ensure that the facility is safe and it's friendly to the sex workers. Because of sex work being criminalized and being stigmatized, the sex workers have a lot of pseudonyms. They have the AKA names a lot. So most of the time they even walk to the facility and they've forgotten which name they gave you the other time. So we've given them an identity and we use biometric. So all you need is walk in and you press your finger and you're able to retrieve your previous health history, and then we're able to give to offer services. So how do we work with this community? This community, it is a well-orchestrated community whereby they have a peer leader and they have hotspots that are being manned by their peer leaders. So we work with the peer leaders to ensure that we're able to follow this community up to the community level, and we're able to find out who has actually missed services and who is actually due for services, or if we have a new girl in that hotspot. So what they do is, they don't allow any girl to, move from one hotspot to the other. So if you actually working as a sex worker in hotspot A, you're going to work in that hotspot and you're not going to allow to move to the next hotspot. So that makes it easier for us to work with them through their peer educators. So those are the hotspots that they actually work in. We normally go to the hotspots to take services there. We provide preventive services. We take PrEP. We take ART refills for those who have not come to the facility. We take condoms. And we even do HIV testing. We have a tent and we have a mobile clinic there. So when you do that, we're even able to reach the clients, sex workers, for those ones who are going to be tested, they can actually be tested during that particular moment. So those are examples of the brothels, the hotspots that are being operated in, and that's where we actually go. We also have the home-based hotspots, whereby the ladies, they have a stool, like that chair that they're sitting on is called a stool. So they sit on that stool outside. So if you are a client and you're looking for a sex worker and you see her sitting on that stool, it means she's available. But when you see the stool is empty, it means she's inside, she's busy. So you have to wait for the other client to come out, and then you can enter. So that mostly is done by foreigners who are not operating from the busy hotspots. Yeah. So because of COVID, when COVID happened, what happened is we had night curfews. So there were no movements allowed at night, and most hotspots were actually closed. So the sex workers, which we normally refer to girls most of the time, they actually moved to online. So they went, online. They advertised themselves online for clients to get them. So what happened is the sex workers outreach program, which is offering healthcare, also moved online. I went to the sites that they're advertising themselves and added the advertisement there, whereby the sex workers are able to see where can they access the free HIV/AIDS treatment in case they're in need of that. So a new entry in Kenya, we have identified another hotspot, whereby we have very young Vietnamese and Chinese who have come in the country. They actually, selling sex. We don't know how they entered into the country. They don't know how, they are not even able to speak English. But we are lucky to find one Chinese doctor who did her PhD in Kenya and did it with the sex workers outreach program. She's able to actually work with them and bring them on board. So we're offering them prevention services, HIV and treatment, care and STI treatment as well. So the sex workers outreach program has been able to do a lot of studies from the early 1979, 80s and all that. So among the few studies that have been done, we have the cohort study that was done by, the title was Use of Clinical Care Database by the University of Nairobi, University of Manitoba Research Team to evaluate HIV prevention, care and treatment in Kenya, because we have followed the sex workers for over 40 years in Kenya. We have also done some work with the mother and child, cohorts for over 30 years. And we have a very big database that we are following under a cohort study. We also have some microbiome study, the clinical history of rectal and urethral STI among MSM. characterizing microbiome host immune interactions for diagnostic and vaccine advances. This was funded by NIH, and it was a very interesting study whereby some oropharyngeal GCCT were done, and it was found that there was a lot of GCCT in oropharyngeal compared to anal and the penile regions. We also have studies in HPV, evaluating mucosal and systemic immune correlates of human papilloma, clearance among sex workers accessing health services through the Sex Workers Outreach Program, funded by Belinda and Gates Foundation. And then we have characterizing expression of the immune system in HPV infected cervicovaginal tissues among sex workers accepting health services through the Sex Workers Outreach Clinic, also funded by Bill and Melinda Gates. We have several clinical trials that have been done. This one's over there on the board. And then you also have some that completed projects that was either a PI or a co-PI. We did an RDS study to reach marginalized young female sex workers with the SRH HIV services, and it was successful. And we are trying to come up with a large-scale study on that. We also looked at factors affecting health-seeking behavior among men who have sex with men in Starehe sub-county, that is in Nairobi. And then we also looked at determinants of antenatal clinic attendance among female sex workers in Nairobi County, because we realized that there's a lot of abortions that were happening in this particular cohort, and yet abortion is also criminalized in my country. You also have ongoing projects in research, that is factors contributing to uptake of cervical cancer screening among the HIV positive FSW, because we realize there are so many lesions that are being identified among the sex workers. And then COVID-19 effect on social economic aspects of key population. This is a study that actually is being done between Aga Khan University, the Sex Workers Outreach Program, and UCSF. And then we have a study, a protocol that we are writing with UCSF, that is intervention to promote HIV self-testing, PrEP uptake, and continuation among Kenyan men who have sex with men, because we realize there's a problem. There's very good uptake, but when it comes to continuation, we have a very low PrEP continuation among this particular group. So we'd like to know what is happening among them. And then we're also publishing a book on history of HIV in Kenya, because we realize that right now, due to the PEPFAR funding and the Global Fund that we received in Kenya, we can rarely, see an AIDS patient, see Kaposi sarcoma or oral thrush. So the current young people do not understand how AIDS looked like 20 years ago. So it's good to have a book that they can actually refer to. We're also looking at HIV recency testing with a team from the US. So in future, we are looking at thinking of doing studies around PrEP uptake, both oral and KBLA, because we don't have the KBLA being implemented in the country. We are looking at HPV types related to cervical cancer among KP, because it was interesting, the study that we did the other day. He found that the female sex workers with, HPV type 16 and 18 were not actually getting any lesions. But these other types like 33, 55, they're actually the ones with lesions. So we're wondering, is it that we have different types that are causing lesions in African women compared to maybe women in the UK or in the US or these other Western countries? So that is a study that is that we are thinking of pursuing. And then mental health issues, stigma and discrimination among MSM, because we are seeing a lot of suicide among the MSMs, especially reaching the young sex workers with HIV prevention services. Because you are seeing a lot of unprotected sex among the young people, but there's the HIV infection is not that much. So we don't know if HIV is an aging disease or there's something else that we are missing. And then acceptability of long-acting in injectable antiretroviral therapy. So Aga Khan is the university that I work for that has funded my travel to this place at the School of Nursing and Midwifery, and it is really now collaborating a lot in the key population. It is a university that was first accredited to offer upgrading nursing from diploma to degree. It was chartered the other day, like 2 years ago, to a fully fledged university. So it moved from, implementing, nursing from a small unit that looks like a home to now it has a university complex that is now operating. It has its own, mission and vision, and we look at impacting, knowledge that is quality, relevant, and accessible to many people. So we have undergraduate programs, that Bachelor of Science in Nursing, direct entry, which just started the other day, and then post-basic programs, that is post-RNA to BSc, also to midwifery. And then graduate programs, we just started APN programs and APM. And we had our first class graduating last year, so this year actually, and the next class is going to graduate next year. So I just want to acknowledge the Aga Khan University, the University of California, San Francisco, for having me here, the KP community, the SWOP, and all collaborators. Thank you.
All right. Thank you, Dr. Akolo, for the presentation. We got really different information from Dr. Akolo. So we will now open the floor for questions, comments, both online and in person. Just if you're online, just unmute yourself and then just ask the question or the comments that you have in person as well. Please feel free to ask any question. I have questions, so I want to, but I want to, anybody online? Okay. Yes, go ahead.
Thank you for that wonderful presentation. I am with TV, and so I'm wondering how connected are you on services with treatment prevention, TV screening, and
Do I go?
Yeah, please go ahead.
Okay, thank you for that question. So as I mentioned earlier, with HIV, there was reimagining of TB. So it was a big thing, and actually somehow TB became stigmatized, that the moment you have TB, people actually knew that you're HIV positive, like it was just direct. So you can't offer HIV services without TB. Initially, when we started a facility, when I was the coordinator, we were just offering HIV services and referring patients who tested positive for TB. And we saw a lot of them not going to seek these services because of the stigma, and we ended up losing a lot of patients. So one thing that we did is to incorporate TB into the HIV programming. So it is just outright, like you have to, like when you have a HIV positive patient, the first thing that is even in the guidelines of the government, Ministry of Health guidelines, is you have to start this new HIV positive client on TPT, like prevention therapy. And you've been given targets that 100%, we need 100% of them on TPT unless they are TB positive. So for the ones who actually screen, for TB positive, they actually started on pre-treatment, and they're even given pyridoxine just to ensure that they don't suffer from the side effects of neuropathy. And then after that, in case they get extra TB that's resistant TB, which we actually use GeneXpert to check for that, then they're able to still, access injectable streptomycin on the ground. But if now they get into XDR, then they are taken to a national center isolation where they can actually be kept there until they test negative, because of the expense that comes with treating one XDR patient. So they are isolated until they test negative. So we have the prevention, we have the screening tools that actually have been put in place by the Ministry of Health. When a client walks in, you must screen them for TB. And they are screened for TB on every visit. that they actually come. And the ones who turn positive for TB, apart from receiving treatment, we do contact tracing to their homes, just to ensure that everybody is tested, and whoever is sick, we still even put their contacts on treatment for free to ensure that there is TB is taken care of. So it's one aspect that has been really well covered when it comes to prevention and treatment and tracing. Their contacts.
Thank you for that. Do you find that the different TB you also have to adjust the ART medication?
Yeah, so that is one thing that we really make sure that we have taken our healthcare workers through, because you will find in our setting, it is not the doctors who are taking care of the HIV positive individuals in the facility. It is nurses and the clinical officers who actually prescribe this medication. So right now, our first line treatment for TB is tenofovir, lamivudine, and dolutegravir, 50 milligrams of dolutegravir. But when a client comes in and tests positive for TB, you actually upgrade the dose for dolutegravir. So you are going to give 50 milligrams in the morning for the fixed dose pill, but you're going to add a 50 milligrams pill, a single pill, whereby they're going to take it in the evening. So in a day, they're going to do 100 milligrams of dolutegravir when they're positive TB. Same thing when it comes to, second line cholesterol and all that. So there's a way that you check which particular ART treatment this person is on, and then you find out, are you going to, switch one tablet in the TB kit, or are you going to, upgrade the dosage for this other ART? Yeah, so that we make sure that our healthcare providers are well versed to ensure that we treat TB and still treat the HIV maximally. Yeah.
Good. Thank you. Any other question? Online. So if somebody is interested in working with a key population in Kenya, or how can they actually be able to get in touch with you guys and be able to work with maybe the MSM, sex workers, or the transgender people?
Yeah, good question. So we'll like collaborating, but I can actually give contacts maybe in the chat, and you see how people can reach us. And I can also share information with Jerry, so that anybody who is interested in that can actually reach out to you, Jerry, and see how we can work with the sex workers of the program on key population. Yeah.
Any question? That's my next question. Any any question from online?
Yeah. I also wanted to know if the experience that we have had in Central in terms of their adherence. I saw somewhere like the update of the conversation that kind of data so good, but that was not MSM. So that's the case.
Okay, so PrEP has a lot of challenges. We launched PrEP in Kenya in May 2017, and we had, a lot of trainings about healthcare providers were trained on how to offer PrEP. And we even sensitized the peer leaders of the key population on PrEP. We did, a survey just to find out what their fears. And we found out very interesting things like, in the community, they are being told that when you take PrEP, your liver gets macerated. So you end up diarrheaing your liver. So with that, it was easy for us to, create health messages that can actually sensitize the community on that. Apparently, even after that, we saw that they will walk, the key population will walk to the facility to, like to access other services. But when they are told about PrEP, they are eager to take they are eager to take PrEP. So they will start PrEP. But 1 month down the line, when they're supposed to come back for the PrEP, they don't come back for the PrEP. So you find that the uptake is good, but the continuation is not good. So when we followed to find out what is happening, one thing was coming out that they need to have choices. They don't just want to have one pill. I mean, like one thing that, it is a pill and you have to take a pill every day. Number two is they have no motivation of coming, like taking PrEP. And they gave us good results. They said, for somebody who is HIV positive, what motivates them to take the ARVs is that they're going to keep the virus asleep. That's what they say. They're going to keep the virus asleep. So they're healthy. So why are we giving them, PrEP that is actually giving them side effects? So that one is, like it's a non-motivator. Number two is they are working so hard. They're selling, sex so that they can make money to pay other bills. So why should they use whatever they are getting to pay for transport to come to the facility just to get PrEP? In case they're coming for something else, then they can, think of bringing, taking PrEP, but they can't just wake up and then use money to come and take PrEP. The other thing was, we have this thing called, among the MSMs, that they call stamping. So what stamping means is, if I'm an MSM and Jerry is an MSM, and I identify that Jerry is HIV negative, I work out so hard that I make sure that he gets HIV. So I stamp him with HIV. So the moment I see Jerry with a bottle of, PrEP, it means it's a sure sign that he's negative. He's trying to keep himself negative. So it's going to be my target. So the moment I see you with a PrEP bottle, you're my target. So I work out so hard. They've even given money to make sure that I infect Jerry. So the MSMs were fearful of carrying the medicine to an extent that they even started buying the ART, now the antiretroviral therapy bottles, from the ones who are positive, so that they can empty the PrEP into it. And then when I put it there, you just know, oh, he's positive, so you don't have to work hard to infect him. But the thing is, they're actually camouflaging. The other thing is, when they are going for the OG parties and they're carrying their pills, when they're dancing or walking around, the pills were rattling inside there. So somebody will speak and say, oh, he has medicine, on him, so this person must be sick, and then the clients will not come and buy your services. So there are a lot of issues around PrEP and MSM which we are trying to work out on. We even tried to do surveys on their thoughts about accessing the long-acting injection. Most of them are happy to have it because they say they're going to be carrying it inside their body. Nobody is going to know. But also some are saying that, I know it is a depot. Like once it is inside your body, it takes long for it to wear out. But the pills, when they want to stop, they just stop and it won't be in their body for long. So there are those things that are around, surrounding PrEP uptake, continuation and all that stuff that we are actually trying to see, coming up with studies on how to actually cater that for that.
That's kind of, they just take the date. What they do is they do so I just like that one. I think it's a waste of some of the reports that were coming from here. Research is not like a waste of why this thing really, I mean, extensively in them. They just take the. So I thought the story like.
No, I've seen some studies also in Mombasa, because we also work with cohorts from Mombasa, Kisumu, Yeah, I've seen some studies done in Mombasa among the MSM, and they are just showing the same, that out of the 7 MSMs who said that they are adhering to PrEP, only one had high levels of tenofovir in the blood, not even just high, enough to to suppress them. But yeah, so they are picking the drugs, but they're not taking. For the few who are saying they're picking, yeah.
That's very interesting. Those online, any question? We don't want to feel left out. So, don't know if there's any question from online. So I think so. What I get from this, one of them is the information, how information is delivered to the people. In terms of like the PrEP, I think the knowledge about the PrEP and the some of the things that you heard from the people saying are not necessarily correct. So is your organization doing something around like communicating the right information to the population that you are serving, or do you think that is even important in addressing all the challenges, especially around the use of PrEP and maybe PEP? I don't know if PEP is still being used there. Do you think that is even something to focus on?
Yeah, it's communication is very, very important. So we actually work with the peer educators, as I had actually said. So when we do surveys and we find out that there's miscommunication or there's lack of information in the community, we plan for seminars for the sex workers, whereby we go sensitizing them. We also have IEC materials developed on the same that actually, they're distributed around in the facilities where we have the drop-in centers. We have a screen that is always running with the information. We also have champions who have actually, their work is just to offer, give health talks at the reception where the sex workers are sitting as they're waiting for to access healthcare services. So we identify where the problem is, and then we package this, like addiction materials, and we actually even, structure how we are going to deliver the information from the peer, from the healthcare providers themselves, the peer leaders, and the community itself. And you also said about PEP. Yeah, we have PEP, which mostly at our setting, because we are rarely, give out injectables, is mostly used by the sex workers themselves and not the healthcare providers. Whereby when we have sex workers who are not on PrEP coming with condom burst, they actually access PEP. And most of the time, it's not even condom burst. It's because the client negotiated and he wanted to pay more money for condomless sex, and this person has bills to pay. So of course they'll go for condomless sex, and then they'll come and report it was a condom burst, and then we'll give them the medicine. It's not like if they say that they went, they negotiated for condomless sex, we're not going to give them the PEP, but just to show us that they know what is right. So yeah, that's what happens.
Thank you. Any question from the audience? None online. Okay. So maybe my last question. The facilities that you talked about, and given that sex work is kind of illegalized or criminalized and BBS MSM is criminalized in Kenya, but you have this high number of people. And how do you, so my question here is, how do you get people to sign up for your clinics? Because this is something that you are doing in a coveted environment. However, how do you get people sign up, like come into the clinic, and then because you said you are serving close to 50,000 people, how do people know that, yes, because a first timer will not understand what a soap is, and this is criminalized, and how do you get your clients?
So initially, I said it's a peer-led outreach model whereby you're working with peer leaders. So these peer leaders are sex workers who are actively selling sex, but also they are the heads of their hotspot. So they are heading or manning hotspot A, maybe a brothel A. So they know who is new in that particular hotspot. So when they find a new girl who has just joined the, like the trade, they actually bring the girl to swap. And because, they are the heads of that place, they're the ones who are manning that place to an extent that even if a sex worker gets apprehended, it is this peer educator or peer leader who talks to the police to release this girl. So they trust them. Because they trust them, when they tell them that they can actually access healthcare services free at SWAP without being apprehended, so the girls actually trust them and they come to SWAP. So that is how even it makes it easier for us to follow them. You might have somebody starting ARVs and then they disappear. So we follow them through the peer educators. We tell them that your girl from this, your brothel, hotspot A, has not shown up for maybe 6 months. They're able to tell us if the girl has died or the girl stopped the trade and went back home, or maybe the girl has just not come. So she's able to actually find out and tell her, tell her to come back to the facility if she's not showed up. So it really helps with the attrition of the clans at the center itself.
Amazing. I think the time I'm going to hand over back to Rebecca, but I just wanted to say that, this is interesting. During our conference in Nairobi last year, we have the SOAP has a exhibition table, and we have one of the sex workers and who is also HIV positive and interacted with a lot of people, and that was interesting. And most researchers at the conference got a lot of information from that. So thank you all for joining this afternoon, and thank you for the time. And I also just want to say our conference next year is going to be in South Africa and Johannesburg. The date is yet to be finalized, hopefully by the end of this week. So if you do work in Sub-Saharan Africa, any of the countries, we organize an annual conference called Africa Interdisciplinary Health Conference, and is going to be in Johannesburg in September of, hopefully end of August or early September of 2024. And thank you again, Dr. Akolo, for the wonderful presentation. Thank you.
Yeah. And again, thank you to all that could join us virtually, and thank you to those who could join us here to welcome Dr. Akolo and Dr. Nutter here at IGHS. So thank you, everyone, and I hope you have a wonderful day. If you do want to get in touch with either of our guests today, you can always reach out to us at the center. We're happy to keep everybody in touch, and have a wonderful, wonderful day. Take care.